Senator Hickenlooper.
Thank you, Mr. Chair. Thank both of you for your service. I was at a roundtable in Colorado a while ago, and throughout it, one of our constituents referred to Dr. Califf, which I thought was a really, given the fact that he still has somewhat of an accent, I thought it would be an interesting way to magnify that. And I do appreciate the fact because you have been resilient in seeking more funding. And many of the complaints that we're having are because there's a clear manpower shortage. I'm not saying everything is a result of that, but certainly a significant part of the complaints we've heard so far this morning is a lack of people being able to respond to inquiries, to complaints, to opportunities to redress some of these health-related issues. Let me talk a little bit about sugar connections and dementia. Obviously, you talked a little bit about how almost 3/4 of our food supply is made up of ultra-processed foods. And recently, the researchers are starting to see a possible connection between ultra-processed foods with higher rates of diabetes, and then later in life, there seems to be a connection to dementia. And I understand the limitations of science, and that's one of the big challenges for you all, that every time science leads you in one direction, the unbelievable pressures of profits and corporate quarterly earnings pushes you or presses back in a powerful way. But even as the science is evolving, there is pretty good evidence that diabetes leads to a higher rate of inflammation, damaged blood vessels, which all seem to be a part of the impairment of our cognitive efforts as we get older. Again, this is already a problem, could become much more severe. So Dr. Califf and Mr. Jones, has the FDA come across this connection while conducting research on the impacts of sugar? And how should the FDA and other public health organizations be responding?
Well, this relates back to Senator Murray's question because, as you know, we don't have much of a research budget. We're not a research organization, so we're very dependent on other entities, particularly NIH, but also the industries that are regulated. And I want to come back to a comment on that in a second. But there's no question. I mean, this is what I do for a living as a professor. I'm a cardiologist. I've been talking about this for 30 years, and the data is getting stronger and stronger. I happen to have 2 sons, as you know, that live in Colorado and 4 grandkids. You're in a state where it's in the culture to eat better. It's normal in Colorado to eat healthy food. I'm from South Carolina, so I feel like I can say this. It's not so much in the culture in South Carolina, and you see it in the difference. There's a report last month. We're now up to a 24-year difference in life expectancy, depending on where you live in the United States. Senator Cassie's from Louisiana, no offense, but very similar to South Carolina in eating habits. And so the evidence is very clear that, and I don't think any experts disagree, there's some general things you should do. Exercise, eat less fat, sugar, and lower sodium. And as long as we're in an argument about whether the government should mandate things or whether people should have a choice, and that's not resolved, we're up to the culture of the place that you live. Now, one final comment about your question about research. One noticeable thing to me, and I readily admitted when I took the job I was not an expert in food. I've learned a lot in my 2 stints at FDA, but one really big difference is when the medical products industry does research, by law, if it's done on human beings, it is made public. Right. And we have access to it, and we look at the raw data and analyze it ourselves at the FDA. The food industry does massive amounts of research that we have no access to. And we don't know what they're doing. We don't know what's guiding their decisions. And it would be a lot better if the research that was done on human beings by the food industry was made public.
We agree. I'm going to throw out another question. You have to answer quickly because I'm about out of time. But the University of Colorado Denver Diabetes Research Center runs a program to recruit young faculty into diabetes-related research, and it's estimated that obviously the number of type 2 diabetes patients is going to rise astronomically in the next 40 years, maybe 70%. How do we prioritize the research that, and as you say, the NIH is doing all these different pieces of research that are all disconnected, whereas we see diabetes or obesity really being a common connector. We had a hearing yesterday with the Global Down Syndrome Foundation looking at all the different places that we're not spending doing enough to interconnect all that research.
Well, again, far be it from me to tell NIH how to allocate its research dollars, but I will point out diabetes is an interesting example because there's a National Institute of Diabetes, Digestive Disease, and Kidney Disease, NIDDK, which is very diabetes focused, and I feel like they do a very good job. The general issue of a 16-year-old who's obese and might develop diabetes later, and what to do about a normal human being who's not sick, doesn't have a disease yet, is a big issue that I think needs more attention.
Thank you.
Senator Murkowski.
Can I just interject for a point of clarification? That 24-year difference you speak of is not entirely attributable to diet or to nutrition. It's many other things, for example, gunshot wounds. So just to make that point.
Completely agree and much appreciated. And there's going to be a big presentation next month from the group in Seattle that generates all these statistics. I would really urge people to tune into that because it will cover all of the different intersection of all these issues that are creating these discrepancies.